Good evening, everyone. I'm Allison Elsner, Executive Director of the San Bernardino County Medical Society, and on behalf of SBCMS in partnership with Riverside County Medical Association, or RCMA, we'd like to welcome you to tonight's presentation, COVID Treatment 2021, Outpatient Successes, Alternatives, and Options, panel discussion number 2 regarding various aspects of the COVID vaccine. This is the second session in our series developed and led by Dr. Eric Hansen, which will build on the previous discussion about outpatient treatment options for COVID with an in-depth discussion about the COVID vaccine from multiple perspectives, including medical, clinical, and administrative. Before I introduce our presenters tonight, we wanted to let you know that you can submit your questions in the chat feature on your Zoom screen dashboard. Dr. Hansen will be facilitating the question and answer session, and we'll try to respond to as many of the questions as possible. So let's go ahead and introduce our participants. Our leader tonight, Dr. Eric Hansen, DO, FAAFP, Family Practice in Hesperia, California. Dr. Hansen established his own family practice in 2002, is a board-certified ABFM primary care physician, and graduated from Western University of Health Sciences College of Osteopathic Medicine of the Pacific in 1999, where he also serves as clinical professor. He currently serves as the trustee for the CMA Solo and Small Group Practice Forum. He also serves as a frequent presenter on how to establish a successful telehealth practice and is a member of the California Medical Association's COVID-19 Task Force and Healthcare Technical Advisory Committee. He is past president of SBCMS and was awarded Best of the Desert in the general practice physician category for 7 consecutive years. He is exclusively affiliated with Choice Medical Group and Choice Physicians Network. Thank you for coordinating this tonight, Dr. Hansen.
Thank you, Allison.
Chaya Prasad, MD, MBA, pathologist and chair, Clinical Sciences Department, and associate professor of pathology at College of Osteopathic Medicine of the Pacific in Pomona, California. Dr. Prasad, a board-certified anatomic and clinical pathologist, is an associate professor at the Western University of Health Sciences. In this position, she is chair, as mentioned, of the Clinical Sciences Department and the director of the 2 longitudinal tracks, Lifestyle Medicine and Business in Medicine. Dr. Prasad is also an affiliate member of the medical staff at San Antonio Regional Hospital. Dr. Prasad completed her residency at OHSU in Portland, Oregon, followed by a fellowship at Harvard University, during which she received several NIH awards, including the prestigious Physician Scientist Award. Dr. Prasad worked at Kaiser Permanente for over 2 decades, where she held various administrative positions. Welcome tonight, Dr. Prasad.
Thank you very much.
Michael A. Sequeira, MD, FACEP, Public Health Officer for San Bernardino County Department of Public Health. Dr. Sequeira was appointed as the county's public health officer by the San Bernardino County Board of Supervisors in late November 2020. He has extensive experience in clinical and administrative emergency medicine and leadership, having served over 25 years of medical directorship and 15 years as a regional director for over 16 emergency departments, with a special emphasis on quality improvement, operations, and advocacy. He served as Director of Quality for Risk for the Physician Partnership of Vituity with 3,600 physician members and 3,400 PAs and FNPs. He is currently Clinical Professor of Medicine at UCR School of Medicine and Western University of Health Sciences. He graduated summa cum laude from Pomona College in Claremont, California and UCSD Medical School, and served his internship at UC Davis Residency in Emergency and Internal Medicine at Oregon Health Sciences University in Portland, Oregon. Welcome, Dr. Sequeira. And our final speaker tonight, Roger Seheult, MD, pulmonologist, Beaver Medical Group, Banning, California. Dr. Seheult is Associate Clinical Professor at UC Riverside School of Medicine and at School of Medicine and Allied Health at Loma Linda University. In addition to being a preceptor for PA and medical students, he was the medical director for the Physician Assistant Sciences program at Loma Linda University School of Medicine, for a sleep lab in the area, and for the Crafton Hills College Respiratory Care Program. He currently practices with Beaver Medical Group in Banning, California, where he is a pulmonologist and sleep physician. He is certified in internal medicine, pulmonary diseases, critical care medicine, and sleep medicine through the American Board of Internal Medicine. Welcome, Dr. Seheult. All right, Dr. Hansen, we're going to turn this over to you to get started.
Thank you so much, Allison, and thank you also to the folks at San Bernardino County Medical Society and also Riverside County Medical Society. Without you guys, we wouldn't be able to reach out to our colleagues and also to the patients of our county and actually across the United States, because I know we have people that are joining us from all the way to the East Coast. And so thank you to everyone that's joining us, but also especially thank you to our expert panel. And thank you for introducing them. That was a whole lot of stuff to say there because there's a lot of credentials on that panel. But first off, I wanted to say congratulations to Dr. Seheult. We have a celebrity here with us tonight because he has achieved over 1 million followers on his YouTube channel, MedCram, which actually is a service that he provides for information, medical information. But specifically, he's had, since the onset of the pandemic, information available that's been vetted and actually really amazing information and interviews that he's done with people from across the world regarding COVID-19 and offers that information for free. So first, I would like to say thank you and a big round of applause to you. Because that's a big deal. And any kids out there, they know that that's a big deal, a million followers. So, and I just wanted to say a little bit before we get started on really the goal of tonight's talk. Anyone that was actually in on the previous presentation, the main objective of that presentation was to be able to share information with fellow colleagues and patients, I should say, regarding the outpatient options on treatment of early phase COVID-19 infections. Because of the fact that I saw in especially my community, but really across the state and maybe even across the country, that we were not coming together with a cohesive plan on the treatment of outpatient COVID-19 and potentially allowing patients to get sicker and ending up at the hospital and having poor outcomes. And so early intervention has been a major thing that is absolutely necessary. And that information is essential to share between colleagues. And so we, at the close of this, hopefully the Medical Society can help us, but we'll close with providing links to the previous presentation for any physicians that are joining us for the first time tonight and would like that information on those treatment options. And then also the link to tonight's presentation recording if you want to share it with other colleagues, because I think it's really important that as physicians and as patients that we're as educated as possible. And in this situation, there's never been more essential need for that. That said, the first portion of the talk tonight is going to be in somewhat of a wrap up to that previous presentation on outpatient treatment options, because it seems like on a daily basis, and I'm sure our presenters will agree with me, that there's new information coming out every day, every week on new options on treatment of COVID, basically. So we're going to talk about a few of those things. The majority of the talk tonight, though, is going to be geared towards the vaccines that are available for SARS-CoV-2 virus and infection. And this is essential, I believe, even more than at this point, the outpatient treatment, because we are at least seeing some downturn turn in the numbers of cases, although every case has the potential to be just as deadly as 25 as opposed to 1. So we still have to have a strategy on how to treat. But now with the vaccines becoming more and more available, we need to make sure that everyone understands the science behind those vaccines. We have a lot of individuals out there that are not certain about if they want to even get the vaccine or if there's dangers to it. There's a lot of information on the internet that is a lot of times based in false science or misunderstandings of the science. And so I wanted to really utilize our expert panel tonight to help weed through that and hopefully help people make a decision that's based on facts that have been vetted from an expert panel. And so that's the real goal. And so I'll even kind of remind our panel of that too, because I know we have a lot of technical information to get across. And so we're going to try and do that in a concise way so that we don't lose our audience, because we don't only just have colleagues on this program, but we also have general public as well. So we'll try to maintain that so that we stay focused on that goal. But with that, I'm going to start talking a bit about these new findings that we've had that have come out. And Dr. Seheult, I wanted to kind of talk to you first. I know there was an article in the American Journal of Medicine that came out talking about early outpatient treatment. And they were talking about some of the things that we discussed in the first webinar a month ago including even hydroxychloroquine and azithromycin and inhaled steroids. Do you mind giving us a brief summary on what they came up with in that documentation?
Well, there was a number of recommendations. What we've come to at this point is the understanding that in terms of azithromycin, in terms of hydroxychloroquine, hydroxychloroquine has gone through a number of different studies. In fact, there was at one point in the research where 60% of all of the randomized controlled trials at the very beginning of this pandemic involved hydroxychloroquine, because this was something that was being looked at very carefully. I think most of the data, in terms of randomized controlled data that I have seen being published, shows that hydroxychloroquine really hasn't panned out to what they thought it would be. And it may be because of something that we're now just finding out. There are two ways that the virus can enter into the cell. And one of those, of course, is the ACE2 receptor. And the feeling was that hydroxychloroquine caused zinc to go into the cell, and that shut down the RNA polymerase. As it turns out, there's an accessory protein that can be used that the virus bypasses the hydroxychloroquine. And that, in fact, in a very elegant study that was recently published in the last 2 weeks, may be the reason why we didn't see hydroxychloroquine doing as well as it might have. So there's still, the research is out on that. In terms of azithromycin, azithromycin is a antibiotic, of course, and it also is an anti-inflammatory. It was being used extensively at the beginning because it was felt that if the patient had secondary bacterial infections, that would be something that we could use, also reducing the inflammation. As it turns out, we don't see a lot we don't see a lot of these secondary bacterial infections, at least clinically. There was a paper that was just published actually a couple of days ago on autopsy that seemed to indicate that the patients who died of COVID-19 actually had about a 30% prevalence of secondary bacterial infections in the lung. But the conclusion of the study is that the patients really didn't die of those secondary bacterial infections. It was something else like renal failure or et cetera. So I think the recommendation for azithromycin at this point should be use it if you feel like the patient's got a chance of having a bacterial pneumonia. And I'll tell you another reason why I would try to limit that. I can imagine that infectious disease specialists would be very for utilizing those only when you believe a bacterial infection is there. But there's another reason, and that is that there is some associative data, at least at this point, that patients with severe COVID-19 versus mild COVID-19 have a different type of bacterial colonization in the GI tract. And so that begs the question is, if we wipe out that bacterial colonization and we have more pathological bacteria than beneficial bacteria, could that have an impact on the severity of COVID-19? Now, right now, we only have associative data. Association doesn't necessarily mean causation, but it gives us pause to make sure that we're not really using a lot of antibiotics unless we need to use those. So that's the issue regarding azithromycin, hydroxychloroquine. There's been a number of other medications that have come online in the last couple of weeks, like fluvoxamine. We can always talk about ivermectin. There's also the STOIC trial with inhaled budesonide. I don't know if we want to talk about those now or later.
Yeah, well, I think that the one thing as far as the American Journal of Medicine, that article was really, I think, pointing out that they identified that there was absolute need and benefit from early intervention. So I think that we agree on for sure. Regarding, since you did talk a bit at length about the hydroxychloroquine, I know that there's probably multiple aspects to it, either the benefit or if it's doing anything or not. And I think that the anti-inflammatory effect, like they've noticed with colchicine, which is another medication that reduces inflammation without as much immune suppression as you get from the corticosteroids. So do you agree that in the early phases that potentially utilizing medications similar to that may have benefit if you notice there's a significant inflammatory cascade occurring?
Yeah, there definitely seems to be some evidence, at least that colchicine, of course, which is an anti-inflammatory, it's used in gout, of course, can be beneficial. Some of the data that I have seen, ironically, has shown, at least early in the course of the disease, that the innate immune system, this is the part of the immune system that secretes interferon, this is part of the immune system that is involved with phagocytosis, is actually suppressed in the early phase, and this causes a delayed type 1 and 3 autoimmune inflammatory condition that causes the patient to develop pneumonia and end up in the hospital. Whether or not these immunomodulatory type of medications like hydroxychloroquine or colchicine are beneficial, I think probably will need larger studies, but at this point, I don't see much harm.
Yeah, and in
Yeah,
fact,
I think I think hydroxychloroquine's there have been so many actually random prospective studies to really show no benefit that, and it's not without its own side effects. And if we were to treat on an outpatient basis, I just as soon have a lesser toxic drug than hydroxychloroquine. And there are a lot of other options. The other thing I found, and Roger, you made a great point, is coexisting. People forget just because someone's COVID positive that people with chronic lung disease and asthma need to be treated for an exacerbation of their underlying disease. And so, and that brings to mind the azithromycin and the use of steroids and budesonide as well. So I think people forget that. And just because they have COVID, that you don't jump to anti-COVID without treating the rest of the patient.
Right. And I think that, obviously there's a gray zone to all of this because, the potential for utilizing some sort of mechanism to reduce inflammation. I think that's a key component, and especially with the multiple different manifestations of COVID, between dermatologic, rheumatologic, pulmonary, cardiac, right down the line. So the question would be then for our clinicians out there in early phase, if you have someone that's presenting with chest pressure, shortness of breath, dyspnea on exertion, they've got their fever, they've tested positive, they're maybe 3 days into this, that inflammation is taking off, and how would you recommend that we delay that process or suppress that? Because if we gave, say, Medrol or something along those lines, that I believe maybe would be counterintuitive, where if we can potentially decrease that inflammation by other means, that's been my strategy. And it's been successful in the clinical field as far as that is concerned, because the fact is, since March of last year, I can speak for my patient panel that I have had patients that I've treated right off the bat with, a protocol of, and we discussed these in detail, but as far as vitamin D, zinc at specific doses that we discussed before, so people can look those up. And then also inhaled corticosteroid if there was respiratory manifestation. And then ivermectin, but that was only after about November that was becoming more of a potential source of improvement in reduction of viral load. But prior to that, I would reserve hydroxychloroquine for if their case progressed. It seemed that the inhaled steroid for the respiratory manifestation made a huge difference. Like within hours, people would feel significant relief. And so, but never did I utilize a oral corticosteroid in those patients. It seemed like that was potentially more indicated for late phase hospitalized patients. Is that something you would agree to?
Yes. So the UK recovery trial was pretty clear that that 6 milligrams of dexamethasone worked much better in your late patients on ventilators with a number needed to treat in almost single digits versus a patient who was barely on oxygen or not on oxygen at all, in which case there really wasn't any type of benefit. And so that was the framework. And we knew that, fairly, I would say around September, October of 2020, after getting a late start on steroids. What was a little bit paradoxical was why inhaled budesonide, which of course is a steroid, would be beneficial in these early onset patients and reduce hospitalization. And now looking at the data, it could very well be that what you need in the lung is an anti-inflammatory. And of course, that's supplied by the dexamethasone late. But what you don't want to do is suppress the immune system or the innate immune system early on in the course, because it's still trying to reduce viral replication, et cetera. Right. So it may very well be that inhaled budesonide early in the course is beneficial, as shown by some of these trials like the STOIC trial that recently was published. But leaving dexamethasone, systemic anti-inflammatories like those steroids late in the course when the patient's admitted and hypoxemic.
Right. That's exactly how I've been practicing, but I have not been afraid to give hydroxychloroquine in the patients that seem like they're progressively declining in the 48-hour window after starting the other routine. And I've seen significant improvement. And you'll see a mix though. You'll see some that respond and some that don't, but even sometimes so dramatic that 12 hours later, you have a patient that's on the verge of needing hospitalization and intubation potentially, and the EMTs come and they won't take the patient because they're too far gone, and starting on hydroxychloroquine, and the next morning they're alert, awake, and not in distress. So that kind of clinical experience is hard to deny, right? So that's where I was trying to pin you down on that. I know it's a difficult subject.
The only thing I would say in regards to that is we've got a situation where 1% of the people who contract COVID die. 80% of the people who come down with symptomatic disease recover without having to go to the hospital. So we just have to be careful with, because we don't know if they recover, if they would have recovered anyway or not. And I know that there's a timing issue, but we just have to sort of look at the randomized controlled trials if we want to know if something works or doesn't work.
Right. Well, not to belabor that one, we can move on to the fluvoxamine, because there have been some preliminary studies, I understand, that actually showed some potential promise with that. So could you comment on that and its role in maybe cytokine production?
Yeah, so fluvoxamine is potentially considered to affect the alpha-1 receptor, which has apparently some effect in the cytokine storm. And there was a study that was published in JAMA, the JAMA network, looking at fluvoxamine and how it's beneficial in terms of progression of ventilator and COVID-19 effects. So the question is whether or not fluvoxamine would be beneficial. It was a relatively small study, and it was a short follow-up, but certainly its effects are promising, and it was randomized controlled. So I think at this point, as a clinician looking at this, you'd have to sort of look at the risks and benefits of your patient. There are side effects for fluvoxamine. It's an SSRI, and you'd have to look and see what kind of drug interactions there would be. But if it's a low risk situation, it may be something you might want to consider. But in terms of knowing whether or not this works at this point, like we would want to get, FDA approval, it's got to be a bigger study.
Right. And just for the folks in the audience that maybe aren't familiar what an SSRI is, that's a medication for depression. So it was really an odd thing that came out that was showing that a medication for depression would actually have an effect on COVID treatment. So really encouraging, and maybe, obviously something we'll have to cover again at a later date. There was one more thing before we leave the meds, really, because there was a recent study on ivermectin. There was a randomized control study, I think, or they're maybe planning one at Temple University in Philadelphia. Do you have any data on that, or any ideas on when that?
Not yet. They're still recruiting, and we should have more information hopefully in the next few months.
Okay, cool. And then you had already talked about the dexamethasone, because there's been some other studies on that and its role and utilization. And probably for you, Michael, I don't know if in the ER, are you guys utilizing that at that early phase prior or during time if you had to intubate a patient, for instance?
Yeah, well, I think we get to the point of significant hypoxemia, and to the extent that we're using high flow oxygen and or considering intubation, we certainly give a bolus of steroids and start corticosteroid therapy for sure.
Right. There's been some studies that are showing that utilization is beneficial as well, as Dr. Seheult had mentioned. And so to keep the ball rolling, there was one thing that's going to be really, I think, important as time goes by, because I've actually already started to do a few referrals to pulmonology. So for me in primary care, I'm seeing patients that had their COVID symptoms back in November, October, and they've progressively had dyspnea on exertion, shortness of breath, chest pressure, basically significant pulmonary symptoms despite the use of corticosteroid inhalers by myself and whatever treatments I have done up to that point. So there's potentially going to be more and more cases, I anticipate, of what we're calling now the ICD-10 code of post-COVID syndrome, or long haulers, or different names that have come out. And so I wanted to kind of talk about that. And part of that is potentially, in my estimation, going to possibly incorporate the utilization of biomarkers, or basically tests that potentially could indicate levels of inflammation. I think we all kind of see that there's inflammation that is the key behind all of this, even when the virus is potentially not at levels that are detectable anymore in our body. So with that, I wanted to ask Dr. Prasad if she could give us a little insight into the potential utilization of these biomarkers, but more kind of, if we can, leaning towards the outpatient setting, because I think the inpatient setting, well, it's important, and they may already be doing things like D-dimers. And I mean, Michael, you're probably ordering maybe C-reactive proteins and D-dimers because you're ruling out PEs, pulmonary emboli, and those kinds of things. But it's interesting, I think, to potentially utilize these types of tests to maybe kind of stratify in the outpatient setting. And so with that, I'll leave it to Dr. Prasad.
Thank you, Dr. Hansen. Let me pull up my screen. Can you see my screen?
Yes, thank you.
Perfect. Okay. So we're going to move to testing.
Oh yes, I went out of order on you. I'm sorry. We had already agreed
No
you were
problem.
monoclonal antibodies, but yeah, if you don't mind.
No worries. All right. So this is a long list of laboratory tests that have been used in the past 1 year to monitor patients with COVID, both outpatient and inpatient. This is an article from late 2020, Clinical Chemistry and Laboratory Medicine. Now, all these tests that are listed here have obviously been abnormal. Not going to go through all of them, but I'll give you a quick run through some of the most important ones. So you can categorize these lab results as either CBC markers, inflammatory markers, metabolic, and so on. Now, the largest meta-analysis study that was done earlier, either early this year or late December, looked at over 200 articles, and most of the studies that they have compiled, this is the end result of that study. So basically, if you look at lymphopenia, numbers less than 1,500 had a threefold higher risk of poor outcome, and this was seen in 28 out of 28 studies. So that's pretty remarkable. The hypothesis here is that the lymphocytes express the ACE2 receptor, and as a result, they're attacked by the virus pretty much as the virus attacks the host cell. The other theory is that the cytokine storm that is created also can cause apoptosis of the lymphocytes. Now, thrombocytopenia, again, in the hospitalized patient, but very early in the disease in symptomatic patients, can be seen in outpatients too. The theory is that it's a consumption, and that's why the thrombocytopenia occurs. These patients usually present with hypercoagulopathy. The cytokine storm can lead to antiplatelet antibodies, which can destroy the platelets, pretty much like how it happens in ITP. And that's another thing that's a theory that has linked the vaccines with the thrombocytopenia, which seems to be idiosyncratic reaction. We can talk about that a little bit later. And also the ACE2 receptors can suppress the bone marrow stem cells. MDW, NLR, I'm going to come to that in a minute, but PCT, procalcitonin, has been used as a biomarker for early detection of bacterial sepsis for quite a while now. It is easily available in most of the laboratories. Elevated PCT has a 5-fold associated increased risk of severe infections. CRP, which is a very non-specific acute phase reactant, this has indicated that elevated CRP levels really correlate well with disease severity and development of pneumonia very early in the disease. So both in patients, definitely in patients, but can be used in an outpatient setting too if the patient is symptomatic. The CRP alone can be one of the most effective and sensitive biomarkers in predicting the COVID-19 disease progression. They also noted that it was elevated in 86% of individuals with severe COVID-19. Combinations have been recommended. A combination of PCT and CRP together would be very helpful in evaluating the severity of the disease in ARDS patients. The other one that is important in the market is the IL-6. Again, this is one of your cytokine storm markers. Elevated levels definitely in patients with ARDS, cardiac injury, secondary bacterial infections, anything that requires ICU admission. Significant difference has been noted between non-survivors versus survivors, again, in the hospital setting, not necessarily in the outpatient. Given that it has a significant role in the cytokine storm, and also it has its value in predicting the severity of the disease, it makes it an ideal therapeutic target. So that I will leave you guys to talk about.
Yeah.
Combination of IL-6 and CRP, again, a really good combination that can predict severe complications, such as the need for ventilation in patients. Combining IL-6 and D-dimer has demonstrated over 90% sensitivity and specificity in predicting severe disease. Coagulation, I'm not going to go into PTT, they're not markedly elevated. LDH, again, 5-fold increase in poor outcome. HS troponin, high sensitivity troponin, is a very good indicator of pending cardiac-related morbidity and mortality. So that's something to keep in mind, especially very early in the disease onset. MDW has been on the market for a while as a marker of early onset sepsis, bacterial sepsis. It's very similar to RDW of the immature red cells, the ones that you see in iron deficiency anemia. Here, the monocytes are the first elements that come in as part of the innate immunity of the body. When you have bacterial sepsis, what happens is that the monocytes get activated, they become a little bit larger, and you get a higher MDW number, a numeric value. Now, this is something that is routinely available in most of the labs, along with your CBC and your differential. So you might want to start paying attention to MDW numbers. The MDW numbers show significant differences in COVID-2 negative patients versus COVID-2 positive patients, so definitely useful in the outpatient setting, and also definitely in patients with mild versus severe diseases, significant numeric value differences. NLR is the neutrophil to leukocyte ratio. And again, this is very easily available on your CBC with the differential count. It's a good predictive value for assessing disease severity and mortality. Again, very early in the course of the disease. It can help identify, triage, and initiate appropriate treatment early in the disease. It can differentiate between moderate to mild disease. It can differentiate between severe to critical disease, and can also predict the onset, the possibility of death in these patients. And for all these studies, they use the SIRS and the QSOFA criteria and scoring system. T cell, this is something newer on the market. You can look at your lymphocyte count, CD4 positive cell population and the CD8 population, B cell population, NK cell population. They showed a negative correlation with disease severity. So the higher the number, the poorer the outcome, and so on. So basically, again, this would have to be a send-out test. It would not be available routinely in your laboratory. This can actually differentiate between mild and severe disease, can also differentiate between survivors versus non-survivors. So that is kind of a basic overview of the laboratory tests that are available in the market and how you can access those.
If you could bring up the first slide you had, Dr. Prasad, and Dr. Seheult and Dr. Sequeira, I'd like to maybe pin you guys down, Dr. Seheult first. I'm sorry, oh yeah, there's the summary. Out of these tests, and because of in the outpatient setting, and this is great for predictability, you know, for patients that are inpatient, you want to kind of see how are they going to do, are they on the verge of intubation, are they going downhill, whatever. But in the outpatient setting, maybe in anticipation of what we may see as clinicians over the next few months to come, if you have patients that seem to have, you know, progressive symptoms that have just not improved. I've got patients that are still can't smell or taste 6 months later now. And I've got patients that have significant shortness of breath when they exert themselves over 50 feet. I have people that can't lift their arms over their head anymore because of severe joint pain in their shoulders, all since COVID. So in those types of patients, do you anticipate the utilization of any of these studies to help us determine how we can approach those patients and potentially help them? And you,
absolutely. Yeah, absolutely. The things that I would concentrate on in those type of patients who are having especially dyspnea on exertion is going to be heart in terms of myocarditis, because that is certainly a sequela of COVID-19. Also looking at thrombosis. We know that patients who die of COVID-19 are 9 times more likely to have microthrombi in the pulmonary vasculature. And the other one I would look at, so myocarditis, thrombosis, and actually heart attacks. congestive heart failure, elevated pulmonary artery pressure. So what would be the test I would order? BNP, first of all, that would look at congestive heart failure. So that's a brain natriuretic peptide. And if that's elevated, I would order an echocardiogram, especially looking at PA pressures. Number two, looking at CK to see whether or not there still is evidence of myocarditis going on. That would be elevated with that, and also troponin. Echocardiography would be absolutely invaluable there in terms of looking at that. But the other thing I would also order is the D-dimer test. It's a very common, unfortunate story where patients are recovering from their COVID-19, they're discharged home, and then they come in with a thrombosis or a DVT. I had a patient today who had that very same thing. So a D-dimer test is very important. And there's one other distinction I'll say before I hand it over to Dr. Sequeira to see if he has any insights here too, is if you're looking for thrombosis in the lungs, this is very, very important. Do not order a CT angio if you're looking for thrombosis after the fact and it's a chronic situation. If it's acute, if your patient has a sudden onset of shortness of breath, a CT angio is perfectly appropriate. But if you're concerned that the patient may have a chronic thrombotic state in the lung, these are typically very small thrombi distally, and CT angios are very poor in picking those up. I would highly recommend, if that's the case and you're looking for small chronic thromboemboli, is to get a VQ scan. That is the best way to make that diagnosis.
And one quick one before you go, Michael. What about inflammatory markers specifically? Because, you know, as far as the other manifestations, they seem to be inflammation driven. So would you recommend any of these tests or even an extra test like an ESR?
Yeah, so ESR is very non-specific. It's a good one to, if you want to just rule out a bunch of stuff. But CRP, fibrinogen, these are all excellent tests to use to looking for inflammation. We would hope at this point, by the time you're seeing in the clinic, that the inflammatory markers have come down significantly enough, and that things are getting back to normal there. But if you're looking for that would not be a bad test to order.
And I think the big question that all the doctors on this, and also patients too, say, well, that's great. So you order tests, now what? So what do you do with that information? And that's where I think the key is. And I mean, you can maybe comment on that real quick. And then Michael, I'm sorry, I keep taking it away from you.
So getting a standard 12-lead EKG in the clinic is wonderful, because if you've got global ST segment elevation, you've made your diagnosis of myocarditis or pericarditis specifically. If you've got elevated CK levels, troponin, you get the cardiologist on the phone, make sure the patient is not exercising or exerting themselves. They could get fatal arrhythmias in that kind of a situation. The current recommendations from the American Academy of Sports Medicine, especially in young adolescents, is if they've had COVID-19, they're having pain, or it's been a moderate to severe course, not to exercise for at least 14 days, because you can get some significant issues. There was one recent study that looked at athletes in the collegiate realm, and nearly half of them had abnormalities either on echocardiogram or MRI in relatively asymptomatic cases. So potentially a serious thing. So these are all things that you can do while you're waiting to get back. But you know, the final common pathway would be an echocardiogram and a visit to the cardiologist if there's abnormalities. Final common pathway for shortness of breath would be making sure you're not dealing with microthrombi. If you're not, getting a regular chest x-ray or even a high-resolution CT scan if you wanted more information, because if there's evidence of fibrosis, scarring from the initial insult, that would certainly be a reason why the patient's having shortness of breath. Get a pulmonary function test. If there's considerable restrictive lung disease, that would also give you an idea. The problem is there's so many different ways this virus has of making you short of breath, and they're all very different and distinct.
Yeah, thank you. Dr. Sequeira, go ahead. I didn't mean to cut you off 2 times. Oh, you're muted.
That's fine. You didn't cut me off because I never started. So, yeah, I think I would agree with Roger. I think one of the things that's most important is to try and approach it as scientifically as possible. In looking at the pathophysiology, and there are 2 common pathophysiologic trends with regard to the COVID-19 disease, and then you have to look at basically the long hauler syndrome, which may be a subset, which is a subset of this. But we do know that endotheliitis with subsequent microthrombi is a diffuse phenomenon that occurs specifically in the lung, and that leads to the happy hypoxia type of situation. They shunt. From the start, these people had sky high D-dimers, and they had big time shunts that weren't corrected with normal flow oxygen. So, the role of endotheliitis, which is an inflammatory condition, with the infection and also the thrombosis. So there are multiple studies in New England Journal and actually JAMA about the role of early and then prolonged anticoagulation. I think that that's really important going on. And the other thing is, with regard looking at specifically more at the long hauler syndrome now, is to really look and see what's the inflammatory nature. So the inflammatory markers, I think, are key in this. If they're high, the CRP, the transferrin, and the IL-6, then I think you need to go that route. And so I think anticoagulation, looking at specific end organ damage, looking at the inflammatory mediators with regard to what component that is. If the inflammatory mediators are not that high, then I wouldn't go down that route. Monoclonal antibodies, but if they are, I think it's worth a try. I thought another interesting correlation between long hauler syndrome and the real similarity between long hauler syndrome and POTS, or postural orthostatic tachycardic syndrome, which is an hyperadrenergic type of syndrome. And there's actually a small study, but actually showed the use of this new beta blocker. It's ivabradine, which actually slows the heart rate and actually treats the symptom of POTS. And this was used actually in long hauler syndrome with significant success, but just a small study. So we don't know, but I think again, the approach is to do it scientifically. Look at inflammatory mediators and the role of inflammation. Look at the coagulopathy. Look at end organ damage, and then maybe consider something like that.
Thank you, Mike. Dr. Prasad, I know that
one quick comment, if I can make from the laboratory perspective, I would definitely advocate against ESR. It's too non-specific. It can lead you down the wrong pathway, but CRP appears to be extremely sensitive, and it's a good marker.
Very good. Thank you for that. I appreciate it, because you're right. I mean, it's very non-specific. You get those and you're not even sure what to do with that result because of that fact. Yeah, and Dr. Prasad, I know you have a presentation on monoclonal antibodies, but I know that we're going to run short on time, and so I think it would be wise to go ahead and move on to the vaccines, because we could talk about treatment all night long, but we have a lot of information to get out on the vaccines. And so just as a precursor for that, I wanted to make sure that we really, as I said at the beginning of the talk, talked about the vaccines in as much detail as we can to give as much good information that's reliable to patients and physicians that can then know what to discuss with their patients. Because every day I have patients saying, well, I don't know, doc, what do you think? Should I get that vaccine? I heard it kills people and no one's telling us. Or there's all kinds of stuff they put in them, and I don't know what it is, or it's going to get into my DNA and it's going to change who I am. I'm not going to do that, And so these are conversations I'm having multiple times on a daily basis. And so I know, Dr. Prasad, you have a brief summary, I think, maybe a slide presentation that tells about the mechanism of the vaccines, at least for the Pfizer and Moderna vaccines, I believe. And right now, just so for the lay public as well, I mean, we have 4 vaccines available, I believe, 2 readily available, which is the Pfizer and the Moderna. And then we've got AstraZeneca and Johnson & Johnson, which are making their debuts here shortly. So as far as, who to talk about that, I know all of my panel here is qualified to discuss that. Dr. Sequeira has his unique perspective as the medical officer for the county. So we're going to get to his, but I think it would be wise just to talk a bit about how do these vaccines work. And then we'll get into the differences maybe between them. And I know, Dr. Seheult, you probably got some opinions on that as well. And then also on the rollout, which Dr. Sequeira, you're going to have significant input on that. I know you have some slides for us on that. Like where are we going for the future? So I'll just start, if you don't mind, Dr. Prasad, you can go ahead and just give us a brief summary on how these vaccines actually work.
Will do. Thank you. So before I get into the vaccines, a really brief introduction into the virus. This is the intact COVID-2 virus. It has 3 surface proteins that are expressed on the surface, the spike, the membrane, and the envelope. Within the core is the nucleocapsid protein. The S protein is the one that recognizes the host cellular receptor, the ACE2 receptor, and allows the virus to enter into the host cell. Now, the S protein, again, I have to talk about this because this leads into the vaccine development. It consists of S1 and S2. The S1 has the RBD, or the receptor binding domain. The S2 has the FP, or the membrane fusion protein. The S protein binds to the human ACE2 receptor via the RBD, allows for the fusion through the FP protein between the virus and the host membrane, and the virus enters the cell. Now, this is the reason this RBD domain is very, very intriguing in the development of vaccines. Now, there are 4 different types, as Dr. Hansen mentioned. There is the mRNA vaccine that is utilized by Pfizer and Moderna. Relatively new approach, at least for vaccines. It's going to be the wave of the future, not only for vaccine production, but also for the treatment of cancers. That's just one example. Here, the mRNA here the mRNA instructs the cell. This is the cell. It instructs the cells to make the spike protein, which will then stimulate the immune system. I'm keeping it very simple to start with. The vector vaccines is utilized by AstraZeneca, Janssen, and Sputnik, whatever that is. It uses the common cold, the adenovirus, and it's used as a vehicle to carry out the genetic instructions to the host cell to make the spike protein, and this is a DNA vaccine. The protein subunit vaccine utilized by Novavax consists of protein subunits. These are the subunits which are used to infect moths, like the butterfly moths. And these cells then produce pieces of the spike protein, which are then harvested and then made into a vaccine. The last one is the whole killed vaccines utilized by Sinovac. The whole virus is inactivated using chemical or heat, and then is made into a vaccine. So those are the 4 different types of vaccines that are available on the market right now. I do have to give you one brief overview about the mRNA based vaccine. The mRNA that is used by Moderna and Pfizer is genetically engineered. It has a 5' cap, which is maintains the stability of this mRNA fragment and allows it to be translated. The 5' UTR untranslated region, it allows for ribosomal binding, which you'll see in a minute. The ORF region, the open reading frame, stimulates the production of the neutralizing antibodies. It has an S1 and S2 segment that we've already seen, regions of the RBD, the 3' UTR, mRNA stability again, poly A tail, mRNA stability. So basically what we are trying to show here is that this mRNA is very, very unstable. So we are trying to make it as stable as possible. If you don't stabilize it, it will be degraded very quickly in the host cytoplasm. So one other thing that is done is 2 proline mutations have been created in this RBD region to stabilize it. So it gives the host cell enough time to recognize it and to stimulate the immune system. Now,
and Dr. Prasad, if I could just interrupt you real quick, I think you just made a really important point. The thing, and I think some of the information that's out there on the internet is that once this mRNA is introduced into your cell, the impression from people that may be somewhat educated about this and those that are not, is that this sticks around in your cell, floats around, keeps doing functions. And can you explain to us what happens once it is coded for those spike proteins? What happens to the mRNA strand?
Right. So this, like as I said, this mRNA strand is very unstable. So if we did not provide all these multiple layers of stability, normally what would happen is even before it gets translated, it would be destroyed by the cellular mechanism within the cytoplasm. So even with all this, layers of stability, it goes through a few cycles of translation, makes spike protein, and then it is degraded. It does not stick around in the cytoplasm of the cell at all. That's one point. The second point, there's a lot of misconception. It does not go into the nucleus. It does not get incorporated into the host nucleus at all. It is purely cytoplasmic. So 2 points to keep in mind.
Right, and that's so essential because there's so much information out there, I should say misinformation really, because people feel that once they take this vaccine, it's going into their cells, it's staying there, and they're going to become part vaccine or something, right? And so then there's that, but then you have the others that you'll get to about the different technology utilizing DNA. So we're going to need to make sure we clarify what happens in that situation as well, if you don't mind. You can keep going.
And Paul Offit, one of the prominent vaccinologists as well as the Moderna and Pfizer estimate that the mRNA maybe lasts 18 to 24 hours before it's destroyed. So I like to emphasize that to my patients.
Thank you. Yeah, that was actually a question I was going to ask. It's like, so I was going to ask the entire panel. So this is making spike proteins. Is it making spike proteins in every cell of our body, or is it specific cells of our body?
It's in the myocytes of the deltoid muscle. That's where it's being made.
Yeah, so right in the ejection site, right?
Yeah, it can be taken
the muscle cells.
It can be taken up by muscle cells, and in addition, definitely muscle cells, also by the dendritic cells or any of the nucleated cells. So it can be taken up by other cell types too. And I will definitely touch upon the DNA vaccines too. So let me quickly run through what happens with the immune system. So as I mentioned, the mRNA is very unstable. So it is protected in addition by a lipid nanoparticle, a phospholipid bilayer. Once this phospholipid invades the nanoparticle invades the host cell, it releases the mRNA into the cytoplasm. There's the nucleus. This is purely cytoplasmic. The mRNA uses the cell's ribosomes or the rough endoplasmic reticulum to make the proteins. This process is translation. So two proteins are expressed on the cell membrane, MHC1 and MHC2, sorry, M1 and 2. MHC2 is found in the antigen-presenting cells such as the lymphocytes, B lymphocytes, macrophages, and so on. MHC1 is present on all nucleated cells. Now, once these proteins are expressed, this attracts the immune system, such as the T helper cells, which are then activated. They start producing all the cytokines. Again, this is very, very simplistic. These are the ILs 2, 4, 6, 10, etc. These interleukins, in turn, what they do is they cause the B cells to proliferate. They differentiate into plasma cells. They become the memory B cells. They start making antibodies, which are directed against the S protein, and these will then neutralize or destroy the virus. And that's the end goal, right? So one of the things that
I'm sorry to interrupt you so many times, but you're hitting so many important points here. So one big question is, when an individual gets exposed to COVID-19, they get sick, they get over it, they have an immunity. We're anticipating potentially 3 to 4 months, and my colleagues here may have opinions on that, but that's what we're seeing, I believe, in the clinical world, where we're seeing reinfection after negative testing happen. Why should we think that this vaccine should protect us for potentially 1 to 2 years, whatever the manufacturers have stated? Why is that different than getting the virus itself? And that's a really key thing, and I was interested in all of your opinions on that.
That's an interesting question. And I think when you get hit by, again, please, everyone else join into, this is my theory. When you get hit with the actual disease, it's almost akin to the first dose. But with the second dose, you're priming your immune system, you're priming your memory cells for long-lasting immunity. How long is that immunity? No one knows at this point in time. But the first onset of the disease will produce enough monoclonal antibodies, or actually it's more of polyclonal antibodies, which have a shelf life, which have a certain limited duration within the body. That is my theory. Michael and Roger, your theories.
Yeah, Roger,
we've actually,
go ahead, whoever.
Yeah, we've actually seen, this whole phenomenon, and actually something to remember is that people can continue to test PCR as well, especially PCR positive, up to 180 days after their first episode. So if you're going by just PCR testing, reinfection may not actually be occurring, and then there's the whole issue of asymptomatic and pre-symptomatic positivity as well. So the big thing is that the immunity induced by a primary COVID infection is very non-uniform. So it can, we know 40% are asymptomatic, and we can't measure the degree of T cell and neutralize T cell activation, CD4 count activation, as well as neutralizing antibodies. So that's why it's recommended. The CDC recommends that even though you've had COVID before, you definitely should have the vaccine, because it produces really strong production of neutralizing antibodies, as well as CD4 killer T cell memory cells activation. So
And I think, Michael, one of the other things that we've noticed is one of the new recommendations that are coming out is people who've had COVID, a disease, they don't necessarily have to have the 2 doses. Again, echoing what you and I just said, the first dose itself would be adequate enough in these individuals to elicit the cellular immunity.
And Roger, your opinion?
Well, I mean, time is going to tell, right? The proof is in the tasting of the pudding. But you have to realize that SARS-CoV-2 has about 25 to 28 different proteins. And when the macrophages and the dendrit and these APCs, basically antigen-presenting cells, digest the native coronavirus, it's going to present all of those proteins to the cell surface. And so you're going to have antibodies made against 25 to 28 different proteins, all of which are irrelevant in shutting down the virus unless the protein that's made is against the spike protein. And so one thing that the vaccine pretty much guarantees is that you're going to get antibodies against the spike protein because that's the only protein that's being made in the vaccine. Whereas with the native infection, you may have antibodies against any one of those proteins that are inside the capsule, which of course is going to do no benefit. So that may be just, it may be a theory, but it's certainly a reality that you've got 25 to 28 different proteins in the native infection that are going to be antigenic. It may also be the reason why you might get a broader autoimmune response against the virus than you would perhaps against the vaccine. I'm not an immunologist. It sounds like we've got some people here in the audience that might be immunologists that could spread some light on that. But in listening to Shane Crotty, who's an immunologist down in La Jolla, he's done some great research, and we've actually hosted him on the MedCram channel talking about exactly what happens in this situation.
And Roger, you make a good point there because after the COVID infection, the CCP that is obtained has less of immune-producing effect than does the monoclonal antibody for the exact same reason, because it is truly polyclonal.
Wow, that's actually so fascinating. And so that kind of actually goes into the next thing that I was going to do. And maybe Dr. Seheult, you can maybe comment on this. We see that there's differences in the efficacy on early study, at least, for these vaccines, with Pfizer and Moderna being very close, with Pfizer maybe 95% effectiveness, Moderna about 94%. With AstraZeneca, I know there was some mixed results of about 62%, and then with Johnson & Johnson, potentially 66 to 80, depending on where you were, because it was studied potentially in third world countries where there was malaria and other things that were factors in those studies. But do you believe that the differences we're seeing are in the type of immune response then, if it's broad or if it's narrow?
There's a couple, so it's hard to compare apples to apples and oranges to oranges. The first thing that you got to know in the Pfizer and the Moderna study, they defined success, or they defined failure if there was any type of COVID, even mild. And so the bar was pretty high in those studies. Whereas in the Johnson & Johnson one, for instance, it failed only if there was moderate to severe. So mild was actually a success. So bar was a little bit lower. And even in that situation, the Johnson & Johnson efficacy was 66%. Why would that be? Well, Johnson & Johnson did their phase 3 trials much later in the season. They did it in countries where there was a high incidence of these variants, for instance, South Africa, Brazil. But even though they had a 66% efficacy, that was, if we look at South Africa, for instance, which is where they did part of their phase 3 trials, 15% of their phase 3 trials were done in South Africa. And even down there, where 95% of the COVID-19 that people were coming down with was the actual South African variant, nobody that got the vaccine in that phase 3 trial, nobody who got the vaccine died or were admitted to the hospital. So where we're seeing the bleeding, the breakthrough, the decreased efficacy is in these mild, very mild to moderate cases. That's where we're seeing a drift on that efficacy. So I still think that people ask me, if I didn't have a choice, if I signed up to get the vaccine, which one would I get? I would hate to see people turn down one brand for another. Just get the vaccine, because they're all going to be doing about the same thing, in my opinion.
I completely agree, Roger. And that I have already heard. I heard the health director of Orange County say that, he's not going to encourage the Johnson & Johnson because of the efficacy. But when you look at they're apples to oranges again, because the Pfizer and Moderna vaccines were not tested in South Africa where the variant is, and we know that there's significant resistance, albeit not clinically significant in terms of prevention of severe disease and death. So all of them work, and actually we're within public health. We're thinking that we're going to be hopefully using the Johnson & Johnson more on people where we can't follow up, homeless people and itinerant transportation workers and those type of people, because the logistics of a second dose is a headache, I can tell you right now.
And so, Michael, I know you've got some slides, and I just wanted to finish up with Dr. Prasad, because did you have another slide on the DNA vaccine? So I know Dr. Sequeira's got a great presentation for us, but I wanted to finish up because there is a difference between the Pfizer and Moderna, and then as far as the DNA vaccine. Do you mind touching on that? Because people see that or hear that and they feel, okay, this one is going into my nucleus of my cells and changing my DNA. Can you clarify for us the reality of that real quick? And then Michael, for you, if you have your presentation after that with your slides.
I will keep it very brief. So AstraZeneca and Janssen uses the DNA vaccine. So what it does is it uses the chimpanzee adenovirus, which houses the DNA molecule. The DNA expresses the S peptide. So once it's injected into the body, it enters the host cell, releases the DNA into the cytoplasm. The DNA then migrates, as it should, into the host nucleus. But most important, it does not get incorporated into the host DNA. It stays separate from the host DNA. What it does, it uses the host cell enzymes to convert the DNA into mRNA, the process of transcription. Once the mRNA is created, it migrates back into the cytoplasm. Just as we saw with the Moderna and Pfizer, the mRNA moves into the cytoplasm, and then the rest of the story is similar to what we've seen with the other mRNA viruses. One other point that I want to make here that's important is that the DNA that is used in these vaccines is a non-replicating DNA. In other words, it cannot replicate on and stay indefinitely in the host cell. It has a very short lifespan. It does not replicate. It is destroyed by the cellular mechanisms. Again, 2 points. It does not incorporate into the host nucleus. It is non-replicating.
And it's not really a chimpanzee product. So I prefer not to call it a chimpanzee adenovirus. It originally was recovered from, it's a coronavirus, that attenuated coronavirus. Is that right?
Dr. Prasad brought up some really important points, because those are really the key of the information that I've seen out there with the folks that are trying to say, oh, you should not get this vaccine because this is what it does to you. And so you've actually spelled that out very specifically. So with that, though, I'd like to move on to Dr. Sequeira, because in his position as a county medical officer, he's got some really important information that we can't all just get by Googling something. So I really was looking forward to him giving us, as brief as he can, though, some information on where we are now and where does he anticipate we will be in the future. But anyway, go ahead, Michael.
Okay, so Eric's giving me 3 minutes for his talk. So
me.
I will move on into this really quickly. We really, what I want to do is give you a brief overview and then talk about the vaccine. I think this is just dramatic to look at what's happened just within our county. Can you all see this, both these curves? This is the July curve. We thought we were in trouble, and this is the December curve. And if you look at the rapidity of descent in this curve, and the estimates from a lot of the epidemiologists, we may have an element of herd immunity already. It's estimated in Los Angeles County alone that up to 55–60% of people are natively immune already, just due to infection and asymptomatic infection. So I'm just going to quickly go through these, and these are our confirmed cases in San Bernardino County. These are our deaths, and you can see the deaths here, 2,500. Our case fatality rate is pretty good at 0.89%, and just to show that we've actually, considering the case fatality rate for our secondary peak is much less than the case fatality rate of the first peak, and I'm just going to basically talk. These are today's data. Our adjusted case rate is now down to 14%. It was over 100 The case rate is the number of cases per 100,000. In December was over 100. Our positivity rate is 6.1. This is important because this will, at 25, will allow us to open up our TK through 6 schools. This is at 14 and below, we can open up our outdoor high contact sports. So that's a big thing for our community and the positivity. If we hit, if we can get this down to, if we can get the case rate down to 8 and the positivity down to 7, we will actually go to red tier. And that's a huge thing for our businesses as well. So I don't know whether they have time, but I think the timeline of this is so powerful that on December 31st, the WHO reported this mysterious new pneumonia and described it in Wuhan. And by January 11th, 12 days later, they reported the first death. And they actually, the Chinese scientists published the DNA, the complete DNA sequence of this virus in that time. They sequenced this virus in 12 days. And within 2 days, 20 vaccine groups were working on this. And I mean, that's just astounding how powerful that is. And the first vaccine candidates by February 10th were already designed and being manufactured. And then the vaccine was entered into phase 1 by March. So look at this timeline. Really, in 3 months, we sequenced this genome, we spread it through the world to every immunology and vaccinology lab in the world, and developed within 3 months a vaccine. I mean, it's powerful. And the other thing is, and if we have more time, and what I tell people with vaccine hesitance is the mRNA process was developed 15, 20 years ago. They've been working on it. The last 2 years of our influenza vaccine are produced by mRNA techniques. So, and I actually wanted to show you just real quick, within San Bernardino County, we've already given 314,000 doses. Look at the US experience. As of today, 65 million doses have been given. Globally, 213 million. Do you think we have a record of safety yet?
Yeah.
213 million.
If I could, your comment, I'm sorry to interrupt you on this one, but I know our panelists, some of them have other meetings to get to, and I wanted to make sure we didn't go too long. But on that subject alone, I looked up the CDC's latest information on complications because they tracked these vaccinations. Folks that they voluntarily logged into their app, and it was a tracking app. And I know I did it when I got mine. So that data was available. This was only about a month into it. And you may, as the medical officer, have more, urgent or latest results. But you just mentioned, I mean, 65,600,000 doses provided. Now, out of that data, there was, there's data that shows how many adverse events. So the people on the internet that are saying, oh, people are dying and no one's telling us, they're tracking these things. The most common things that I saw was pain at the injection site, which you would expect because you have your muscle cells basically making being exposed to the mRNA and making those spike proteins so that you can have antibodies made. So we would expect that to occur. Feeling of mild fatigue, maybe like a headache, these kinds of things were some of the higher on the list. I went through just one after another of every single potential side effect. And it's very common all the way down through all the age groups. It was the same thing and resolving within usually 48 to 72 hours. And the adverse events of cardiac arrest and those kinds of things were almost identical from the placebo, meaning they didn't get a shot, to the people that did. So do you guys have any other opinions on that as far as this data, or do you have any other information? Michael first.
It's all yours, Eric. But anyway, so it's extremely safe. Anaphylaxis, the experience with anaphylaxis is overall 5 per million for Pfizer and 2.6 per million for Moderna. Those are the big ones. And mortality has been basically zero compared. There are 58 total deaths in the U.S. And no more than control. So this is our county experience, and we've given 288,000 already, and you can see the rollout, and it's been difficult just because we have so little vaccine, and we had to categorize it by phases and tiers, so it's difficult. And so Chaya already talked about that. And then we have had personal experience with the variants. The B117, which is the British variant, we've actually we did some really good work, but there's been a small outbreak in Big Bear Lake, and we found 2 people. The family knew someone who traveled to England, and then basically it spread. We had 4 confirmed cases. It was at least 12 people up in Big Bear Lake. I think we've successfully contained it. It hasn't been found or isolated anywhere else, and we're doing genomic sequencing for anyone who's been in the Big Bear Lake area, and of course with the ski season and with Super Bowl up there, we were really concerned. But and the B117 is 56% more transmissible, but no significant increase in disease severity, and vaccines are still effective. So this is, and the Scripps Institute estimates it may become the dominant strain in March, and that's why we have to continue basically using our social distancing and masks, et cetera. And it's a race really to get everyone vaccinated, because the faster these viruses grow, the more variants are produced, just because, and you could see the curve. The more people are infected, the faster this virus is replicating, and the more the variants occur. We haven't seen any of the B135, that's the South African. It is more infectious. There is some decrease in vaccine effectiveness. I've seen it in over 30 countries, and in California we've only seen it 2 cases, one in Alameda, one in Santa Clara. And then the Brazilian variant we have not seen in California, and it's similar to the British variant. And this one has a total of 12 mutations, and it's been seen in 4 countries. There are 3 cases in the U.S.
Right.
And then there is Eric, I'm just going to keep going, okay? And then the California variants, and these are quite common in Northern California, and are thought to basically account for up to 25% of all the variants of all the COVID infections in the Bay Area, and there are multiple infections mutations, and so that's basically our experience. And I can open it up for discussion of variants and also the vaccination experience. But we have experienced a significant amount of hesitance, and especially in our communities of color, and almost embarrassingly in our healthcare workers. When we roll this out to the hospitals, and anywhere from 30 to 60% compliance or acceptance of the vaccine. So there are physicians on this call, and one of the things I really wanted to make sure that we stressed is physicians are leaders within the medical community, and we have to speak out and speak to the safety and efficacy of this vaccine. And it's astoundingly safe, and really, like Fauci said, extraordinarily effective. Despite and we've got to get people vaccinated before it mutates. So sorry. Had to rush this, but I'm definitely open out for other questions.
I appreciate it, Michael, and I think you made some key points. And Dr. Prasad had pointed out something where she was talking about the intracellular component, and where we're talking about the immunity. Now, the spike proteins, for that to become mutated, and maybe Dr. Seheult, you have an opinion on this as well, for the vaccines to be ineffective, would have to have a very significant mutation, would it not, for the spike proteins to no longer be present? For our antibodies to bind that our vaccines are making. Do you agree with that, or do you have an opinion on that?
Well, what we're seeing is that there may be, and there's actually been some studies that have come out recently that have looked at for instance, the UK variant, and the fact that the Moderna and the Pfizer vaccine may not bind, or the antibodies may not bind as well. Remember that antibody and B cell response is just one variable in the equation of immunity. You've got T cells. You've got a whole host of other things. The thing that I find really interesting is that, of course, here in California, we have our own homegrown variant called the California variant. There was recently a study or a paper that was just put out on that. And despite all of the variants and everything, we're still seeing a drop in cases here in California. So I think there's an in vitro aspect to this. And yeah, the antibodies from the vaccine may not bind as well to these variants in vitro, But if you look at what's going on in vivo, I think we're actually making some headway. The one exception to that I would mention in the things that we're starting to see a little bit of worry on is Germany right now, where there's an increase in 10 out of 16 states there, probably fueled mostly by the UK variant, interestingly. So hopefully they get their vaccines up. And also, I understand that late news in Sweden, we're starting to see a resurgence there as well. But with those two exceptions, I think things are going pretty well.
Well, thank you. And I've got, gosh, there's a lot of things that are really important. I think I'll probably need to just skip ahead to something, because you talked, Michael, about the vaccine hesitancy, especially in healthcare workers. And I know that a large number of maybe the nursing staff and especially maybe even in the childbearing age female physicians and nursing staff and hospital staff, there's been concerns, there's been issues that have been brought out on the internet about safety with pregnancy, about the potential for causing infertility. I'll point out that I know Dr. Seheult has a great presentation on MedCram with a Dr. John Campbell, and then there's also another one that's Dr. Vicky Mail. And Vicky Mail, she's with the Imperial College in London, I believe, GYN, but also immunologist. And she has a great presentation on that. And I should give Dr. Seheult just maybe a moment to summarize that. And then I had a question for Dr. Prasad about some thrombocytopenia potential complication that the CDC was reporting. So if you can prepare for that one. But Dr. Seheult, on pregnancy and on fertility, if you don't mind, real quick.
Yeah, so the first thing is, if you want a complete understanding, look at that video by Dr. Vicky Mail. She's amazing. She covers it very well. But very briefly, COVID. So what does pregnancy do to COVID? Pregnancy makes COVID outcomes worse. Pregnant women are 3 times more likely to end up on the ventilator, 3 times more likely to end up in the intensive care unit. And so because of that, I would actually encourage women who are pregnant, specifically, or if they're thinking about getting pregnant, to really consider highly getting the vaccine. Going the other way, what does COVID do to pregnancy, or the COVID vaccine, I should say? We don't have all the data yet, but if you look at the phase 3 trials for all of these vaccines, they would not allow pregnant patients into the trial. And in fact, when women signed up for the trial, they were told not to get pregnant. But of course, accidents happen, and they've been tracking this. And if you look at the number of pregnancies in each arm of these trials, they're about the same. If you look at the miscarriages in those people who are pregnant in those arms of the trial, it's about the same. We're not really seeing anything emerging at this point that the vaccine causes miscarriages, that the vaccine prevents you from getting pregnant, anything of that nature.
Okay, great.
Yeah.
Thank you. And
Pfizer just started a formal prospective randomized prospective study for pregnancy, and I think both of them are working on that. And we're getting quite a lot of experience with our nurses and other healthcare workers who have subsequently been pregnant, and so far no side effects.
I think currently in the US, there have been about 20,000 pregnant women who have been immunized thus far with no adverse effects.
Mm-hmm. And ACOG has officially come out in favor of the
Yes.
vaccine. So,
that's big. And like I said, again, definitely check out that interview with Dr. Mail on MedCram, and hopefully the staff at SBCMS can go ahead and post those links, maybe potentially to make it a little easier for folks. And I want to kind of pin down the panel a little bit on this. I mean, Michael, I'll start with you. So say grandparents get vaccinated, they get their 2 injections, they say 3 weeks post second shot. What is your advice on them as far as being able to now maybe potentially interact when they've been sequestered for potentially a year? I talk to patients on a daily basis. They say, I haven't left my home since last April. I mean, they are serious. They have not left their home. They haven't not left the room. People leave things on the door. So what's your advice on that, and getting back to living?
yeah, I think it's time for them to relax a little bit. The CDC has actually issued a subsequent recommendation that those who are 2 weeks post second dose can actually now don't have to quarantine after any exposure to COVID. So they've actually relaxed that, and we're still recommending masks and social distancing, but I think in terms of the elderly who are fully vaccinated, who I think just simple basic masking and it is probably fine. And I think the more we can let them go basically back to normal. But we just don't know about the variants yet, and that's why we don't want to let go of the recommendations for masking. But certainly in terms of exposures, you don't have to quarantine for at least 90 days. But and that 90 days is just because that's the safest longest interval we know for with 90-degree confidence or plus.
Right. And I think that you bring up a good point, because the thing is though the graphs you show are remarkable, we see this huge drop, and you potentially can even bring up subjects about potentially herd immunity and things we've talked about before. That does not mean that the cases will not continue to potentially trickle in. And when they do, they are just as dangerous as they were in March of last year or April of last year. And so we have to be as cautious as possible potentially, and also have strategies on outpatient treatment for sure in the early phase. We've agreed on that. But then also the potential for that vaccination, if we do see that it's lasting, we're having these memory T cells that can potentially carry on for a year or potentially two, that can dramatically change how people function on a daily basis. And I think that's the point that we need to get through as well, especially for the folks that are 65 and over, potentially at risk and thinking of twice about getting this vaccine. Dr. Prasad, I know I asked you because there was a couple other complications that were things that potentially could be seen and that are maybe legitimate. And one was thrombocytopenia or low platelet count after vaccination. Have you had any other information on that? Because the CDC was reporting that that was a potential issue.
Right. So looked it up in the literature, and 45 cases were reported of with ITP type syndrome following immunization. This was reported via VAERS. Of the 45 cases that were evaluated, 19 of them actually did confirm to be a form of ITP, which is idiopathic thrombocytopenic purpura. It was equally distributed between Pfizer and Moderna, no particular differentiation between the two. Regarding age, sex, and demographics, no specificity. So bottom line was this was probably idiosyncratic. Perhaps there was an undetected platelet disorder in these patients that might have been manifested. Again, if you think about the cytokine storm and the ability to cause antiplatelet antibodies, that could be the logic behind the thrombocytopenia. And they compared this with other vaccines, which was very interesting, like the MMR and the influenza, which I did not know. MMR has about 3 cases of ITP per every 100,000 vaccines. So when they compared MMR with the SARS vaccines, they found that the incidence was even less than 3 per 100,000. So it is extremely low. They really think it's idiosyncratic, perhaps related to some underlying platelet disorder.
Interesting. And it was very low population, it sounds like.
Very, very low, yes.
Okay. And Dr. Seheult, I'm trying to wrap this up as quickly as I can, but Dr. Seheult, I had a question for you because there was also something floating around out there in the, the netherworld of the internet about the potential of this being a Trojan horse, the vaccines potentially hiding some nefarious coding that potentially would be enacted at a different date to wipe out half the population of the world. So do you have any opinion? I'm sure you have opinion, but can you tell us what your thoughts are on that, or if you're familiar with what that story was and all?
Well, the thing that's very important when you start to talk about conspiracy theories or theories is that you have to have something that's falsifiable. That's the first thing that you have to have before you can entertain it. What type of data will we have that would be able to falsify that? And unfortunately, there's nothing. I mean, they can say it's at a later date, at some point in the future. These are unfortunately conspiracy theories that nobody can battle because they're not falsifiable. So I don't see how we could do a trial to show that they're incorrect.
Okay.
So Roger, the only thing that I could see was in 2012 and 2016, there was some studies that were conducted in mice with the mRNA vaccines, and they did see that there was this immune enhancement reaction, but it has not been replicated in humans at all.
Right. And that was the next question. You anticipated me. The potential for this causing a hyper-inflammatory reaction, and Michael, I should take you on this one first. Have you seen anyone that has been vaccinated yet that has come in that potentially got exposed to COVID and then had this severe inflammatory reaction occur? Have you heard of that yet? And any of the ones on the panel, but Michael first.
No, actually, I haven't seen it. It's certainly within our county and within the millions in the U.S. I think that's there's at least some pathophysiologic basis to that, like on the basis of the COVID disease. But I was smiling because I thought Chaya was going to say that there was some study in mice that showed that microchips were actually injected with the messenger RNA. So I'm glad you didn't say that, Chaya.
I would have to be really far right to say that, and I'm not far right.
So, all right, so that's important because I think the principle was, and why I even put it on the agenda, was the potential that I suppose there could be some scientific reasoning behind that, that if someone was that atopic or sensitive and there was a cytokine production that was exaggerated because of the antibodies that were made from the vaccine. I don't know if Dr. Seheult, maybe you have an opinion on that as well. If that was something where you would potentially see this huge inflammatory response that could cause tissue destruction or organ damage. And if so, if you did notice that this was occurring, what would you do to stop that? Would that be a course of steroids? Would that be markers that you would order?
Yeah, it would be mostly a course of steroids. I guess if the plan was to do this in everybody, I don't know why they couldn't have done it in the flu shot. Everyone was getting, at least most people were getting the flu shot in higher amounts than they're getting this vaccine, it seems.
Yeah.
Right, meaning that if someone wanted to do something nefarious to the population of the world, they surely could have put it in flu shots for the last 25 years and not waited for this. And so yes, another great point. So I think that, as far as the major topics on, the fertility, a big one right there, I think. And then as far as the safety with pregnancy, a huge one. As far as the true data that shows how much have we seen so far out of the millions that have been vaccinated so far, that data is undisputable as far as safety, in my opinion, when you look at the science. And so it's easy to read something on the internet. It's easy to get just bits and pieces of information that may even scientifically seem sound, but when you look at it in its entirety and you dissect it like we've done tonight, I think that you can feel that you've got people that understand this at a level that they're confident. I imagine all three of you had your vaccines. Did you?
Yes.
I don't want to put you on the spot, but it's important. So, and I did as well back in November. So I think it's really the take-home message was, especially for, and Alice is raising her hand, I think the take-home message really is especially geared towards our healthcare providers out there that are not really sure about the science. I hope that from this, they were able to gain something to hopefully change their mind about how they feel about this in the big picture. There's always going to be the potential for someone to have an allergic reaction. You inject anything into somebody, that can occur. And I think we all agree on that. And Michael, you may have some statistics on those adverse events that may have happened. I don't know if they were due to significant allergic reaction.
We're still awaiting more evaluation, but just think of that 213 million doses. I mean, talk about a record of safety, and we still don't have anything significant reported. So, I mean, by the way, the MMWR, there was an MMWR on vaccine hesitancy. It's starting to get better, and people who a lot of people just hesitate waiting to see if something will happen, and so they're starting to float up into the 70% now, but it's still in our communities of color are still lagging. So, but I think more powerful than anything is the experience. 65 million already just today in the U.S. and 213 million in the world without any significant reports. So
no, that speaks for itself for sure. And I think we talk vaccines and we talk about the potential that, if these are effective and long lasting, that we could get enough people vaccinated that we really would rarely see this disease. But when we do, like I had pointed out, it will be potentially just as dangerous, if you agree, Dr. Seheult, as any time, although they can maybe lose some virulence as time goes by and mutations occur potentially. But I think that it's important, the take-home message as well to the clinicians on the call and even to the patients as well, that we may see this, and it may be seasonal, it may come and go, and it may dry up kind of like it did last summer and then really bloom. That's always a possibility, but obviously the more people we get vaccinated, the better off we all are. But then also it points to the fact that we do need to maintain some cohesive strategy on outpatient treatment option. And I think we all agree on that early intervention is very important. There's some disagreement maybe about what medications to use, and we're going to need to really look into these things, I think, in much more detail as time goes by, and not give up on therapeutics, because they will have a role. There'll be people that have had allergic reactions to vaccines in the past and will not be candidates. there'll still be people that even after hearing our talk tonight, believe it or not, they won't get the vaccine. And the other folks that, potentially, won't get it for other reasons. And so that is going to be important that we have a plan for those folks, that we don't just say, well, sorry, you should have got your vaccine. So I don't know. I'll leave it with the closing remarks from each of our panelists, and maybe Dr. Prasad first, if you don't mind.
I'll let the others go first while I collect my thoughts.
Okay, very good. Michael or Roger, who wants to go next?
Well, Roger, you have to go. Why don't you go first?
Okay, well, we've talked a lot about, tonight we talked a lot about therapeutics and things. I think something that's below the surface, that's the iceberg below the surface, in my opinion, is mental health, anxiety, depression. A lot of people are having that. There's some recent evidence that's come out that seems to be indicating that 3 times a week, moderate exercise can go a long way in ameliorating not only the depression, but also the anxiety associated with it. So while we do and are calling for social distancing and mask wearing, that can still be done in conjunction with some daily exercise, fresh air, sunlight, to keep us sane during this pandemic.
Great advice.
Great advice.
Michael?
Yeah, I think from a public health standpoint, we have to roll out the schools. We have to open up the businesses, and the only way to do that is discipline with regard to the social distancing, opening it up scientifically, and vaccinating. One last thing I didn't mention was that the FDA just announced today that they were going to fast track any modified mRNA vaccine because it's so easy to modify it to take care of variants. So we're already looking ahead for that as well. So and I think as leaders within our communities, we just have to continue to urge and reassure and educate all the people that we can affect, and physicians and our medical leaders are important in this community, especially in the pandemic. And so I really appreciate everyone that's been here and all the efforts that we all have done throughout this, and we're getting through it. So thanks for having me.
Dr. Prasad.
Well, I think I do need to mention one thing. This is for physicians and all healthcare workers. We are considered the experts in this area, and it's kind of shocking to see a significant number of healthcare workers, including physicians, refusing to move forward with the vaccines themselves. And I think it's an important message here. Please read the literature. Please pay attention to the science. Follow. You're trained in the healthcare business. Get yourself really educated and pass that message on to not only your patients, but also to your colleagues. And then I have to do my usual shout out to laboratory medicine, which is, hey, there's tons of laboratory tests available. Please use them, but use them judiciously. Be careful. And always, if you have any questions, reach out to the pathologist. We're more than happy to talk to you.
Yeah, thank you so much. And I just really wanted to thank our panel tonight. It's a unique situation to have people from different aspects of scientific experience, and it's, I think, super important. It was so important for Dr. Prasad to show us on the intracellular level. I know any one of us 4 could have done that presentation, but it really helps to have a clinician, a scientific clinician that's a professor that teaches students, medical students, tell us, this is what's going on, and hearing that from that perspective. And then from the clinical perspective, Dr. Seheult and Michael as well, because he's in the ER, but more from his standpoint as the chief medical officer from the county level, and seeing this in a big picture and nationally as well, and keeping up on that information is so important for us to get that information, because we don't always get the true story there, I think, when you try to find out. And so we really appreciate you being on this call tonight, or this webinar, Michael. And Dr. Seheult, as always, and you were on the first one as well, and I'm urging that people tune into that one, because we had really detailed discussions on outpatient treatment protocols, and there's some really super good information that even if there's controversy about medications and which ones to use, we really weeded through that on that first presentation. And there's simple things like the zinc and the vitamin D and the exercise and sleep and all these things that were essential for any cases that come up in the future. I anticipate that we'll probably end up having to do another one of these in not too distant future, probably talking about more detail on those long haulers, the post-COVID syndrome, the chronic COVID patients and what do we do with them in the future. And by then I imagine Dr. Schroeder will have a few more that he's seen with pulmonary manifestations that weren't due to microthrombi or other things that were maybe due to inflammatory problems, which is what I anticipate more from what I'm seeing from the diverse effect that this virus seems to be having on patients clinically. So I look forward to those discussions further in the future. And thanks again to the medical societies, both San Bernardino and Riverside County, for all your help in marketing and showing you know, what we were going to be doing over the past few weeks. I know it probably got annoying to a lot of the folks on the call getting these reminders over and over again, but I really appreciate all your work and to everyone that attended tonight. So with that, I'll close and thank you again to the panel. I really appreciate all of your work and everything you guys are doing.
Thank you, Dr. Hansen, for your leadership.
Thank you, everyone. It was a wonderful presentation. Thank you.
Good to see a lot of old friends on this call too.
Thank you.